Assalamu alaikum. I'm Dr. Shahnaz Perveen. I'm speaking from Sydney, New South Wales. I'm one of the specialist general physician working here for the last few years. Today I'm going to be talking about asthma and COPD, how to recognize them in the community early, treat them effectively, and reduce the complication, increase the exercise tolerance, and reduce overall mortality. Although the symptoms are similar for asthma and COPD, these are two separate entities. They both present with cough, wheezing, may present with tightness in the chest, shortness of breath, and cough may be productive. In case of asthma, these sort of symptoms can be worsened at nighttime or early in the morning. But asthma occurs in response to asthma occurs in response to eosinophilic inflammation and mast cell response, and the CD4 count increased, interleukin 4, 5, and 3 increase. In COPD, it occurs in response to neutrophilic inflammation, and there is macrophages come and CD8 T lymphocyte increases, and cytokines are involved, which is interleukin 8 and TNF alpha. So their pathogenesis is completely different. Asthma is responsive to inhaled corticosteroids, whereas COPD is not. That's why we have to be really careful from the beginning so that we do proper diagnosis of asthma and COPD and treat them separately. The triggers for asthma can be a varied of things. Allergen like pollen, dust, cigarettes, smokes other than the cigarettes, fumes, cold, upper respiratory infections, flu, some medications like beta blockers, exercise, and even pets. The triggers for the COPD also can be cold, upper airway infections. Cigarette smoking is a major factor, and smoke other than cigarette smoking as well. In Australia, it's a developed country, 1/3 of the COPD gets undetected and untreated, because most of the COPD patients, they feel tightness in their chest, wheeze, and they cough, and they go to the chemist and buy some bronchodilators and use them, and they get some relief, and they feel that their asthma is better. They don't always present to the doctors and get treatment. So we have to be really vigilant about this. The diagnosis, the main criteria is spirometry. Spirometry is essential to differentiate between asthma and COPD. When the patient presents, we have to do the spirometry. Spirometry shows airway obstruction if the FEV1 and FVC, which is the ratio, is less than 70%. And in case of asthma, if we provide bronchodilator and it is reversible, the patient can blow normally. It gets better, then we can diagnose as asthma. It does not get better, it is COPD. The treatment for asthma is the inhaled corticosteroid. And they can also keep the bronchodilator for necessary before exercise, half an hour before or 15 minutes before exercise they can use it. And while doing exercise, if they get short of breath, they can again use it and keep it with them. For COPD, the mainstay of treatment is LABA, long-acting bronchodilator like Spiriva. And in case they get exacerbations, then we can use LABA-LAMA combination. And even after that, a small percentage of population can get recurrent exacerbations. And if they get hospital admissions or recurrent exacerbations more than 2 a year, we can then add inhaled corticosteroids only. For example, your Seretide or the Symbicort. So that is the last resort for COPD, which is the mainstay treatment of asthma. One other thing I cannot emphasize enough is the technique. It depends majorly on how the outcome of your asthma or COPD treatment will be. So you have to use the puffer correctly. You have to use the puffer with the spacer device if recommended. If not, however, the puffer is recommended, you have to use it properly. You have to learn it properly from your doctor or your nurse. And if you are confused, this is really vital that you learn that. And if your asthma or COPD is not well controlled, please seek attention. And smoking affects really badly on asthma and COPD, so speak to your doctor about giving up smoking. Thank you for listening. I will bring other talks in future for you. Thank you very much.